Assalamu alaikum and good evening, everyone. I hope you're doing well. My name is Dr. Kanza Ahmed Chandio, and I'm honored to welcome you all in this insightful webinar on modern approaches in pediatric dentistry in celebration of National Children's Oral Health Month, February. As the COO of Experienced Dentistry, I truly appreciate your participation today. Our mission is to promote awareness and excellence in dental care, and this session is a step forward in that direction. We are privileged to have with us Dr. Maleeha Ijaz, an expert in pediatric dentistry holding a BDS and an MDS from Shaheed Zulfikar Ali Bhutto Medical University. With her vast knowledge and experience, she will be guiding us through latest advancements and best practices in pediatric dentistry, something essential for every dental professional working with young patients. Before we begin, please keep your microphones muted during the presentation. Feel free to drop the questions in the chat. We will address them in the Q&A session. The session will last approximately 50 to 60 minutes, followed by an interactive discussion. Without further ado, let's begin. Dr. Maleeha Ijaz, welcome, and over to you.
Thank you so much, and I hope you can hear me. And I'm going to start to share my screen. I'm sorry, it would be the entire screen for some reason, and you'd be able to see my notes as well, which I didn't intentionally wanted to do. So today we'd be talking about latest advancements in pediatric dentistry and preventive strategies for childhood caries. And let's see. The contents of the presentation would be advancements in peds dentistry, preventive strategies for childhood caries, and role of diet and lifestyle in childhood caries. So we all know that importance of pediatric dentistry, it cannot be overstated as it serves as a cornerstone in establishing lifelong oral and general health habits. Early childhood experiences that a child has in dental care, it can significantly impact a child's oral well-being, affecting their overall health and quality of life. Therefore, staying at the forefront of advancement in pediatric dentistry and generally in dentistry and specifically the new trends. So new trends, pediatric dentistry as a profession has reformed immensely, largely owing to the advances in technology and materials and disease knowledge. This specialty, it encompasses a variety of skills, disciplines, and procedures and techniques if you have or you are you're well acquainted with it, and it's a common origin with other dental specialties. So, technological advancements affecting dentistry, including laser dentistry, restorative techniques, powerful electronics, novel materials, and enhanced imaging instruments, they have revolutionized pediatric dentistry as well. So first of all is artificial intelligence. So we all know that in this era, artificial intelligence has become a part and parcel of every other application that we are using. So it has also become an integral part of modern healthcare, and with the applications spanning in various specialties, including pediatric dentistry. In PEDS, AI addresses several traditional challenges such as improving diagnostic accuracy and enhancing treatment planning for our young children. And PEDS dentistry often involves managing the behavior of anxious or uncooperative patients. How? Because AI-driven virtual reality and augmented reality technologies, they're now being explored to create more engaging and less intimidating dental experiences for our young population, helping them to manage, helping us as dentists to manage their behavior and on their part, reducing their dental anxiety. Additionally, AI-powered tools can provide personalized oral healthcare recommendations because they're automated. So we know they can help us in giving us specific programs which are like patient-specific and individualized preventive care strategies based on the individual risk factors after assessing that patient, and which can be especially beneficial in pediatric settings. So here's a brief depiction of the areas in which AI is research is helping in periodontics. That is, all the sections or the pie chart is showing like how and to which percentage they are helping us or it is helping us in various subspecialties of pediatric dentistry, like in dental plaque, early childhood caries, and fissure seal and categorization in supernumerary chronological age assessments, and in identification of deciduous and young permanent molars, and overall the oral health and plaque index, etc., and ectopic eruption as well. So next is crowns. Traditionally, we have all been know their PFMs, the porcelain fused to metal crowns that we are all acquainted with in general dentistry or operative dentistry. But specifically for pediatric dentistry, the traditional ones are the stainless steel crowns. Short form is SSCs, and they've been used since and ages and till now, and currently being used as well, but zirconia crowns are the new sensation, as shown, because they are aesthetic, they are biocompatible, and they hide the discoloration, and they're not the teeth and for interior teeth, especially which are affected with the early childhood caries or nursing bottle caries. It is a blessing that we can restore the aesthetics and hence the confidence of the pediatric patient. So nitrous oxide inhalation sedation comes under conscious sedation, and we all know that nitrous oxide sedation it's been widely, I think, used in adult patients or for adult patients. But it's an endolysis process, and it's a safe and effective technique used to manage pain and dental anxiety overall, and this allows as a diminution or elimination of pain and anxiety in a conscious patient because the patient is conscious throughout the treatment, and they respond to your verbal commands. Protective reflexes, they remain unchanged, like their respiration is fine, their heart rate and their consciousness is maintained throughout, and pre-procedural mobility returns when you discontinue the use of nitrous oxide. And it's not like the general anesthesia that after that the child almost suffers for around like 48 hours, that a proper consciousness is restored around in 24 to 48 hours. In the meanwhile, the child is irritable. But in this case, if the child is cooperative and you have fulfilled all the indications or requirements of the procedure or of treatment under this inhalation sedation, the child would be perfectly fine after the treatment. We won't be going into the details of how and it can be used, but it's a thing that should be practiced after you have a certification or a diploma or in a hospital setting specifically. That's for sure. And next is silver diamine fluoride. Of all the fluoride treatments that we have been using till now, silver diamine fluoride is the newest thing. And silver diamine fluoride has increasingly revolutionized dental caries control, specifically the dentinal caries, the open lesions that are not approximating the pulp, but they can be managed with silver diamine fluoride, because silver diamine fluoride being alkaline, around pH having it has a pH of around 10, and what happens is it has silver and fluoride, and it combines with ammonia to form a complex, and it reacts with the dentine and gives you a black staining, and it goes into the dentinal tubules and blocks them. So the application technique is that we usually clear the lesions or the open cavitated lesions from the plaque, or we can even etch it before applying it. We can etch it the same way we etch for composites. And after that, we can use it and this silver diamine fluoride after rinsing and dry cleaning it. And we can just apply silver diamine fluoride to the lesions and wait for around like 1 minute. And then with like gentle air from your triple strand. And then after, and before even starting it, you should be applying petroleum jellies or all around on the mucosal region, avoiding the areas that are to be touched with the silver diamine fluoride. And the most important thing while you want to go for this option for the pediatric patient, you have to communicate to the patient's parents, that it is going to stain the teeth black. So this is a major concern for the parents who are concerned about aesthetics in their children, and for specifically the interior teeth. So what you do is you tell them or even show them the pictures of the cases or on online, or maybe you've done them before. So you can show them that what actually happens in this procedure. Then if you want to manage the stains of this black staining of silver diamine fluoride, you can go with potassium iodide. What happens here is potassium iodide, it reacts with the free silver ions, which is causing the black color, and it turns into a white precipitate instead of a black one. And then you can actually cover it later or on at the same appointment, or maybe wait till you see the signs and symptoms of the rest of the caries, and then you can proceed with either restoring it with GIC or RMGIC or composite even. So this is going to actually block out the tooth from the already present or arrested lesions with a permanent restoration or definitive restoration, in fact. So this is a pictorial description of how the lesions were. And after doing pinpoint, these lesions are treated with silver diamine fluoride and later with potassium iodide. And at the end, they are being restored with a GIC or a composite. Next is lasers. Lasers has overall, it was previously being used in dermatological and aesthetic purposes. And in the beginning, it was when it was discovered or it was invented. Actually, in 1970s, it was carbon dioxide laser that was first invented. And now it has found its way in slowly in pediatric dentistry as well. So what does it do in pediatric dentistry? It does is it serves you hard tissue and soft tissue functions. By using laser, we all know that it's light. So what happens is when you use it, it converts into heat, and with that heat, you get to have many applications. Like apart from this caries detection, where you induce like laser-induced fluorescence to detect the caries, you do prevention of enamel and dentine caries. You do caries removal and cavity preparation. And this is this is what pulpotomy is happening in this picture right now. And next one is soft tissue applications. So on the soft tissue applications, there are more of the soft tissue applications because wherever there is water content, the laser light is going to hit that area and specifically target that area. And it is much more beneficial than the classical scalpel blade method, the surgery that we used to perform for frenectomies, for gingival remodeling, surgingivectomies, and suturing and hemostasis, etc. It's controlling all of it. I mean, and next is exposure of teeth to aid in eruption. You do these lasers to even do the gingivectomies, like it's been shown, and here it's in the tooth that you want to expose it, and you want to just bring it back into the arch doing their orthodontic treatments and even pulpotomies. So what are the limitations or disadvantages? You're already looking at my notes. So it's like you always would be needing like more than one type of lasers. Lasers are expensive. And if you need more than one type of lasers for different applications, like for hard tissues, you would be needing different kind of things, different kind of or brand of laser and different wavelength of lasers. Like we have ND-YAG, we have carbon dioxide lasers, we have erbium yttrium laser, we have diode lasers. So they all have different wavelengths at which they are working, and at different chromophore or the pigment they pick up in the different tissues, dental hard tissues and soft tissues. So they would be used accordingly because you need to have a proper training either from the what you call the companies who are providing you with these laser equipment. And we know that till now, I don't think so we have any formal education of the lasers and its applications while we are in undergraduate and even postgraduate. It's usually the private setups that we get to see these the instruments and machinery. So it's if you want to incorporate lasers, it's going to be it would be high startup cost, and they don't. And the downside is they don't cut metallic restorations. They won't cut through it. And the next is like they're slow in cavity prep. Obviously, it would take longer to heat the hard structure of the tooth, the enamel and the dentine, and you have to incorporate in such a way in your practice that you have to modify your clinical technique where you are using both the lasers and your classical hand pieces to finish the cavity prep where you think that the cavity prep hasn't been that finished the way you want it to be. So this is another one where they're removing mucocele layer. And next is teledentistry. So the integration of telehealth in pediatric dentistry allows for remote consultation. This actually started during COVID when the online consultations were being given because of the lockdowns and all. And you can do now, it is being proven helpful. Like it's giving us a chance to do online consultations, remote consultations, follow ups, monitoring the oral health of a child who cannot maybe come for regular visits or has an emergency situation and want to have a consultation, quick consultation or emergency consultation before rushing or before you directing them to rush to an emergency department of of a hospital or it's a must that they should be approaching a dentist. This approach is particularly valuable for underdeserved populations. It's like a distance education kind of thing, and in situations where in-person visits may be challenging. Now, digital radiography and imaging, we all know that almost all the clinics and even dental institutes are having the digital radiography now, and it has become a standard tool in pediatric dentistry as well. It reduces the radiation exposure specifically, and it's more accurate. It gives instant images. You don't have to go through that developing the films and then the X-rays getting dim with the time. So the recorder is always there online, and it allows for a better visualization of dental structures. And with specific programs or supporting these radiography, you can opt for different options in that programs and help that can help you in visualization of various structures and giving you a contrast and helping you in diagnosis. So in pediatric dentistry, digital radiography has minimized the radiation risk, and because children are more susceptible to affecting their tissues, the effect of radiation on their tissues because they're rapidly developing. And so they are also helping us assess dental and skeletal development and carious lesions and even traumatic injuries when a child has had a traumatic event. So, pulpotomy techniques, yes, there has been a lot of advancements in the materials that are being used traditionally in pulpotomy, from the classical calcium hydroxide to formocresol to MTA to biodentine to lasers. So, these are some of the newer things that are being used. And the success rate of pulpotomies have been increasingly found more with these uh, latest technologies, and they help to preserve the tooth function and structure. This is particularly important in peds dentistry where the focus is always on maintaining the tooth. Whatever you do, you try to maintain the original or the natural tooth in a child's mouth till it naturally exfoliates because it's the best natural space maintainer a child can have. And next is interceptive orthodontics. So whenever you're dealing with children in the early mixed dentition stage, like around 6 to 8 years or 9 years of age, when the dentition is being, the primary dentition is exfoliating and the permanents are taking their place. So you have to keep an eye on the interceptive, the developing malocclusions a child can suffer. And so this interceptive orthodontics has gained more prominence in pediatric dentistry because if you deal with these developing conditions or malocclusions at the very beginning, what happens is you get to decrease the time and the cost of the orthodontic or the permanent or fixed orthodontic treatment later on. Identifying and addressing orthodontic issues in primary dentition, it can help really prevent the severe problems. So these are some of the devices that are being used in interceptive orthodontics. We all know for expansion of the palates, and this is a space maintainer that is given after premature exfoliation of the primary teeth, and this is the classical Halley's retainer, etc. So Next on is preventive strategies of early childhood caries. We all know early childhood caries. ECC is defined as the presence of one or more decade non-cavitated or even cavitated lesions missing due to caries or filled tooth surfaces in any primary tooth in a child under the age of 6. So this is what we know early childhood caries is. So what happens when a child is suffering from early childhood caries? There is a higher risk of new lesions in both primary and permanent lesion. If it's there in one tooth and if the condition is not improving, it's going to spread more in primary and later to permanent dentition. Hospitalizations and emergency room visits, if it's the systemically is it's involved, if it's like a space infection, it turns out to be a space infection, then it's going to be difficult for the parents and the child. High treatment cost, obviously. On the what you call as hierarchy of treatments. The most easiest one would be the pit and fissure sealants, and the costly would be the crowns and the pulpectomies, etc. And later maybe extractions and even space maintainer, etc. So high treatment costs are involved. Loss of school days, that's definite as well, because if a child is not doing well systemically, he or she cannot attend the school. So diminished ability to learn, that is obvious, and it is linked with the same, and reduced oral health related quality of life. And overall, the child won't be leading a good life. I mean, the quality of life would be hampered because the child is not maintaining a good oral health and is not able to eat anything. So what happens is the factors that are associated with the early childhood caries is the breast and bottle feeding in infants and pacifier habits in infants and toddlers, infant formula milks, the diet, caries conducive dietary practices that they get mostly established around 12 months of age, and frequency of between the meals snacking. The frequency, this is the main thing that is contributing to the development of early childhood caries. Increased duration, because it actually leads to increased duration of decreased pH and henceforth caries. And sugar, sucrose, glucose, fructose based drinks, foods, anything is causing that. So what happens here is these are some of the studies that I'm sharing that are that can you can see all you all can see that there have been different studies that are giving you an idea about how breastfeeding and ECC are linked, how dipping the pacifiers in sweetened syrups or sweet juices they're affecting, and how the infant formula milks they can contribute to increased risk of early childhood caries even more than bottle feeding. And there are some of the studies that are depicting about how the 4 to 7 year old children they are affected with the high sugar beverages that they use, the juices and the soft drinks and even stings, etc. So what happens is, as you can see, that according to AAPD, it's like till 12 months or before 12 months, the breastfeeding, if a child is on breastfeeding, it's helping the child to develop the immunity, and it's more on the benefit side. After 12 months or 1 year, if it's not weaned off and the child is being given breastfed like more than 7 times a day, and especially nocturnally, it's going to it is going to increase the risk of the child having more early childhood caries. So American Heart Association even that they say that the sugars and the salts, this should be in a very limited or almost to none that should be served to the children under 2 years of age. So next is caries risk assessment. So this is where it helps, like if a child has presented to you with caries at any stage, at any age, what you're going to do is what AAPD or American Academy of Pediatric Dentistry says is it says that caries risk assessment and management protocols, they are recognized and they're called the care pathways because they help you find out or help you even make a diagnosis and make a decision about how and what treatment should be given to the child according to his age, his caries risk, the compliance the child and the parents are showing, and their essential elements of contemporary clinical care for infants, children, and adolescents. So the two of the caries risk assessment tools that are being validated by the APD is the karyogram and the camera tools. What happens here is next up is a table which shows you a caries risk assessment form of a 0 to 5 year old. So here you can see the risk factors, the preventive factors, the disease indicators, and next to that is high and moderate and low risk columns. So what you do is you mark these according to while you're taking a history and observing the child clinically as well. And then after recording this, you find a balance or you make a decision after finding or weighing all the risk factors and the protective factors and then categorizing the child as either the child falls under the category of high risk, moderate risk, or low risk. This is again another form which is showing how you would be assessing a child more than 6 year old. So the same would be happening here as well. You're going to mark this and then you're going to make an assessment after that. And it sometimes it's not like clearly what you call helps in decision making that if this is happening, then it is definitely a high risk patient. You're going to find a balance in how how the current situation of the patient is. And next is now after you have categorized the patient under any of these three categories, what you do is you do it. Like this is for 0 to 5 year old child. What you do is you do a diagnosis, and after that you are going to make this uh, a chart in your mind that how often you're going to recall the patient. If it's a high risk patient, if it's a moderate risk patient, and it's a low risk patient, and how you're going to instill some preventive techniques like the fluorides, the dietary counseling. Are you going to give it or not? Are you going to just endorse what they're doing? Or are you just going to tell them that this is a no and this is a yes, that these are the things that you're going to do? And either the child needs sealants, fissure sealants, or even the restorative interventions if and when they are needed. You're going to find it after categorizing the child. And same as with the child greater than 6 year old, you're going to do categorization and diagnosis, the fluoride applications, whether you're going to tell the parents how much of the dentrifices or the toothpaste that the child is going to use at home, like how much concentration of fluoride should be there in their toothpaste, and how much would be the quantity of the toothpaste they're using, and how often and how well they are toothbrushing it. All the things that come, and maybe you have to apply the fluoride varnishes and even STF if the parent agrees to the anesthetic appearance or the black stains. So next is what does the APD recommend? It recommends that dental caries risk assessment based on a child's age, social, behavioral, medical factors, protective factors, clinical findings that you have found. This should be a routine component of a new and periodic examination. Whenever you are seeing the patient first time, the child is presented to you, or during having other dental treatments and the child is presented, you're going to look for these things and you're going to assess the child. While there is not enough information at present to have a quantitative caries risk assessment analysis. I mean, you cannot just quantitate like how much sugar a child is consuming, like how many jellies, candies, and etc. they're using, or but you're just estimating children at low, moderate, or high risk by a preponderance of risk factors and protective factors. You're just finding a balance, like how many risk factors are there and how many protective factors are there, and how many disease indicators are there that will enable you to make a evidence-based approach to medical providers that either you're going to treat the child yourself, you're going to retain the child in your practice, or you're going to refer the child to a specialty dentist, like a pediatric dentist, and intensity of the diagnostic, preventive, and restorative interventions as well. So care pathways based on a child's age and caries risk provide health providers with criteria and protocols for determining the types and frequency of diagnostic, preventive, and restorative interventions for patient-specific management of dental caries. So the policy says that non-dental healthcare providers who identify first. Maybe there is a dental auxiliary who is first seeing the patient, because this is American Academy of Pediatric Dentistry's policy. So they have a definitive, what you call a framework or a community where dental community where there are non-dental health providers who identify ECC in a child. They can refer the patient to a dentist. And for you as a general dentist or a person who is not specialized in pediatric dentistry, if you're finding it difficult to, after you have identified though, but you're finding it difficult to treat the patient the way you assume that they should be treated, so you definitely refer the patient to a dentist who has the knowledge. So immediate intervention, if it is indicated, and non-surgical interventions should be implemented, like minimally invasive dentistry and preventive dentistry should be done, and as soon as possible, because it is going to postpone or even reduce the need of any further and more extensive treatments. And because children who experience ECC, they are at a greater risk of subsequent caries development, and preventive measures, like it's going to be a full-on process of like dietary counseling, reinforcement of toothbrushing, and everything. And more frequent professional visits with application of topical fluoride and restorative care are also necessary. So when we talk about preventive or anticipatory strategies, there are two ways. One is preventive and one is anticipatory. Preventive just focuses on actively taking steps to maintain oral health through practices like brushing and flossing. Like you're preventing something by doing brushing and flossing, while anticipatory means that you're actually predicting the potential oral health risks that are coming to with the patient when at a certain stage, like when a patient is at a particular developmental stage or age, and you provide guidance proactively to their parents, like you're predicting it, like these things can happen. So you're actually educating them to have them an idea about what developmental changes that will occur during the visits, and that includes information about daily from daily oral hygiene practices to any and every event that can happen within their child's mouth. So under this preventive strategies or anticipatory guidance, we go for prenatal counseling. If a mother is presented to you if since you are practicing general dentistry, then you're going to see some expectant mothers as well. And while you have them in your dental chair, you can always counsel them on improving their own dental health. Then is development of oral tissues. You can always tell the mothers when they present their children to the dental practices about how the development is going to happen. Oral examination, then there is perinatal oral health, teething, fluoride needs, and pacifier, and digit sucking, and speech and language development, trauma, and medications. So prenatal counseling is, we all know that there are many bacteria that microbes that get transferred and through placenta, through milk, and through gut as well. So this is just to give you an idea about how these things are affecting, and when they does, if there's and after that there is a preterm and low birth weight infants, they're going to experience a higher incidence of enamel hypoplasia, and periodontal diseases, they have been linked to even preterm labor as well. So you're going to tell the mother about the consequences of if the proper care is not done during the pregnancies. So development of oral tissues, when the parents bring their children to you for any visit. I mean, in Pakistan, we don't get to receive the children when their first milk teeth are erupting. We only get to see the patients when they have a problem. They already have a cavity, they have a toothache or anything. So if and when they do, you're going to tell them or educate them about eruption sequences, ages of eruption of primary teeth and associated conditions, and development of chewing, speaking, jaw development, overall physical growth that is going to happen, and hygiene practices, and when and what to do. I mean, you're always going to tell them when you're going to start cleaning the mouth of your children, and how and what kind of toothbrushes, toothpaste, fluoride concentrations in the toothpaste, quantity, and how often, and how are you going to actually brush the technique specifically as well. So these are some of the pictures. First of all, is like natal teeth and neonatal teeth. These are some of the common presentations that we get in our dental departments. What happens is you have to tell the parents about if you're treating the natal teeth or neonatal teeth with maybe extraction, or maybe you're grinding them down to the gum level because they're causing the laceration while under the tongue while they're feeding. So you are going to communicate properly to the parents if you're going to extract them. And if you're going to extract them, then these were the teeth that were supposed to come in the mouth around 6 months of age. And they were supposed to leave the mouth around 6 years. But now, since we have extracted them, there's not going to be any more primary or milk teeth in this space. And next is this child having a white lesion on the palate is the Epstein pearls, and the other child is having Bowen's nodules. So these are the normal physiological things. So you remember them, like pearls are always present on the palate, and Bowen's nodule is always on the buccal ridge. Up, you will get these on them, and you don't need to have do any treatment for these two because these are like self-limiting conditions, and they're going to go away in few months, like maybe 1 month, 2 months, 3 months. And you're going to just keep a close follow up for these patients, but you're not going to do anything. And next is gingival cyst. These also do not need any treatment. So next is oral examination. I don't know if you all know how the traditional way of treating or doing oral examination on a child is making the child sit in the dental chair. But what happens if the at what age should be the first visit? If the child is there with you earlier for any problem, you're going to tell the parents that the first visit should be usually around 6 months to 1 year, or when their first tooth has erupted in the mouth. And how to examine the child, it's usually knee to knee till like 18 months to 36 months, around 3 years of age. You can just do the examination or demonstrate the cleaning procedure to their parents while you're having the child in your lap, the head in yours on your side, and the feet on the parent side. And even for the special healthcare need children, you can just examine them like this in this position, like till 5 years of age. So these are some of the things. And next is the perinatal oral. After the child is born, how to clean and when to clean their mouth. This is an important thing because when a child is even newborn, few days, a month or more, and there is no tooth in the mouth right now, and most of the parents, they are like a bit amazed at this when they're told that you have to clean the gum pads, the tongue, after whenever you are feeding with a clean muslin or a like dampen cloth, and you just wrap it around the index finger. The mothers can clear the mouth, and that's it. Next is teething. They should have an idea about baby teething symptoms. Sometimes they associate differently, like biting. I mean, they're biting things, they're refusing food, they're waking at night, they're crying, they're having rashes, the drooling, there's irritability. I mean, you have to tell them like these would be happening and how you're going to deal with them. And next is how and when the teeth are going to appear in the mouth. The primary, when are they going to come? And you can look for them, and you can tell them that which teeth are to follow which teeth and when they're going to shed anyways. And next is treatment of teething. So management of teething, it can be approached as a five-step process. Like this is the National Institute of Health and Care, NICE Institute of UK, that gives the clinical knowledge summary on teething as that you have to take history, you have to do examination, you have to do diagnosis and referral of any child who is like extremely systemically unwell, and you know that the child is in distress, and you have to shift the patient or refer the patient for urgent medical care, and providing parental and parent and the carer, whoever the primary caregiver of the child is, you're going to reassure them that it's nothing to be worried about, and you're going to give them optimum information and preventive advice as well. Simple and non-pharmacological management strategies are usually employed, should be usually employed, and pharmacological interventions, which include some painkillers, syrups, and drops, etc., they can also be given. And safety netting advice in the case the child is unwell, you should know that the child is to be referred now. And next is how to soothe the child. There are teething toys. We all know we have the teething rings. The teething medicine is there. What happens is teething medicine has the ingredient, we know it's local anesthesia, the topical one, the benzocaine or lidocaine even, and everybody asks that, can we apply it? I mean, you are not going to be able to control the quantity of how much a parent is applying it at home. Even the dentist, if they try to apply it, you cannot be sure of how much the child is going to ingest and how much it is going to affect the child systemically. So what FDA has said is, like this, due to this ingredient, it shouldn't be given to the children under the age of 2 because it has got serious side effects. Like what it does is it's going to anesthetize the back of the throat in that area, and the child won't be able to eat properly. And teething biscuits are there. I don't know if it's in Pakistan, but in the foreign countries they make it like organic biscuits, like with the ingredients, I think oats and all. But what happens is the main ingredients are sugar and salt. And what happens is either the sugar and salt, we don't want the child to be addicted to these two things in the beginning, from the very beginning actually. And the other thing that can happen is the child might be able to break a small section of that, and that might be inhaled and can cause choking and another serious situation. Now, next is cold solid foods. Yes, you can, if the weather is appropriate, you can tell the parents that they can give them like yogurt and apple sauces and anything cold that can soothe them. Other home remedies are, you can use cold items like cold metal spoons. They're refrigerated for some time, and then you can just apply from the convex side on, like you can just massage them on the gum pads. This is going to soothe the child. And the other one is a knotted wet washcloth. What happens is you're going to take a muslin cloth, which is a clean one, and knot it after wetting it and then refrigerating it, and then you can just let your child bite on that. This is going to help the child, and you can also put the pacifier or the teething ring in the refrigerator. You can gently massage with a clean finger on the gum pads, and you can, even some children get relieved with breastfeeding and you can just always give them water if they're around like 6 to 9 months of age. And what happens is, what's a big no? There are teething gels that I've shown you, like the numbing gels, the homeopathic tablets that most of the population is acquainted with, this BC21 that we all have been given most of the times in our childhood, but it is not. And teething necklaces, these are mostly in the outside world. They are like amber necklaces or something. So these are like, they can break. The child can be strangulated and all. So what happens is teething gels and over-the-counter medications, when you rub them, you don't know how much the child has swallowed. And for homeopathic medicines or tablets, what happens is they have an active ingredient which is called belladonna, and it can cause breathing issues and seizures. So it's also a big no. So you're going to be mostly, or most of the times, you're telling the patients or the parents that you have to um stick with the at-home remedies. Or maximum, if you want to, you can just give them paracetamols and brufens for pain. If the child is having any temperature or any systemic issue with that. So fluoride needs are to be assessed while after you knowing that there's no community water fluoridation in Pakistan, and we have to further dig in, like what the family source of drinking water is, in which area. Some of the areas they have more fluoride, and resultantly their children can be affected with fluorosis. and it would depend upon at the age at which they were exposed to that excessive fluoride. And the supplements of fluoride or topical fluoride applications, they can be educated depending upon the needs of the patients. You're going to educate the parents about how important is fluoride for the overall maintenance of their oral health and specifically the mineralization of their teeth. And fluorosis, as already I've talked about it. And next is fluoride supplementation schedule for children. So what happens is this is a classical table that we always refer to is fluoride level in drinking water. And this is with age and with fluoride concentration in the drinking water that you get to decide that how much supplementation you're going to give to the child. So this is how it is, like less than zero point 0.3 parts per million and zero point 0.3 to zero point 0.6 and greater than zero point 0.6. And next is birth to 6 months, you don't need anything. 6 months to 3 years, if it is less than this, then you can do this much fluoride in the diet or topical applications. And next is 3 years to 6 years, and then 6 to 16 years. So what happens next is these are some of the fluoride. This is tooth mousse, which is amorphous calcium phosphate and casein phosphate that we use classically. And next is enamellus or the sodium fluoride, 5% sodium fluoride varnishes that we use chairside. And then again is sodium fluoride. This is in the tube form, and the other one was the unit concentration that you use. That is there for dispensation as for like one-time use. And next is the list of goals. What are your goals when a child? First of all, is you should be telling the parents like they should be encouraged to bring their children for regular dental visits, and there should be dental treatment of the whole of the family. I mean, not just the dental treatment and dental hygiene, and it should be maintained throughout the family. Next is the bottle should be, if they're bottle fed or even if they're breastfed, they should be weaned off, and especially nocturnally. It should be stopped and brushing twice daily with fluoridated toothpaste and water or milk in sippy cups instead of the nursing bottle. So next is this is a table where you can say like this is a circle like no juice or added sugar should be given in the milk or juice strictly under 2 years of age, not at all. And even later, there should be a minimum possible concentration of these things. Healthy snacks should be preferred. No sodas should be introduced. The child shouldn't be introduced to these fizzy drinks. And xylitol gums, if you can afford and if you can find, you can chew on them. And avoid junk foods and candies as well. And the frequency, especially of the kiwis prone junk foods and candies, etc. So next is non-nutritive and pacifier habits. These habits are, we all know, like we all have been using pacifiers while we were young, thumb sucking, some of us have done, and nail biting. And these are some of the, or pencil, chewing on a pencil or any other thing. These are the habits that they are there and they're considered normal if they are self-limiting by 1 year or 2 year. But if they don't, the child do not stop around 3 years of age, then it's going to cause a lot of problems. Like it's going to be playing a vital role in developing malocclusion, like deleterious effects on the dentoalveolar region. Like there would be excessive forces of the cheeks, excessive forces of the thumb they're placing against the palate and on the interior palate. So they're going to be a different type of malocclusions that you're going to get. So this you should be telling the parents about what is normal and what is not normal, and when should that be stopped, and when the dentist is to be consulted. And if they are not able to stop these habits by themselves, they're going to consult the dentist for that. And next is when you get to have the school age children, you can talk to them directly and about what like you can do the counseling on if they're doing nail biting. You can just not only talk to them and about their bruxism, their clenching. It should be done directly because you get to find out the reason. You really want to know about the reasons why a child is clenching teeth or is suffering from bruxism at night and nail biting, etc. And the consequences of consuming acidic foods should be elaborated to the children as well, because as the children grow, really you really get results when you talk to the patients or your young patients because they do understand it. And next is pacifier sucking. For pacifiers, never dip them in flavoring agents or never let your child share the pacifier with another child and never leave an infant unattended with the pacifier in the mouth. If its size and if its shape is not you don't know because most of the parents don't even know about what designs of pacifiers should be used at what ages. Do not let your infant sleep with the pacifier because this the child gets conditioned with this that if the child is having a pacifier or a nursing bottle in the mouth, then only the child can sleep. So these habits would be difficult to break later. And there should be regular cleaning of the pacifier because if a pacifier is being used, it has to be cleaned super often. And next is you have to wean them off, obviously, because it's not like a lifelong thing. There are ways, like in this picture on the left side, it's like what you do is you can shorten the frequency and length of time. You can manage your child's emotional state, like how much. Uh, First of all, is you find the right time to start. I mean, you have to find it out that you have to stop it around like 1 year of age, or the child is habitual of it till later. And then you're going to introduce an alternative comfort object. It can be an activity, it can be a toy, it could be a new anything that is going to distract the child. Limit the periods of time your child is using it. I mean, when your child can use it, you're going to limit it. Maybe except sleep. And you can later just shorten the frequency and length of time. Then you can manage your child's emotional state. Then, when you see that how much your child is emotionally attached with the pacifier and using the positive reinforcement and be consistent. Like you can maintain a calendar that how many days have you just been how many hours and how many days you have been like pacify free, and then you can just give them small token of or rewards that can just help them do this positive reinforce their habit of not using it more. And later you can just what you can do is in different countries or on internet you might have come across different like saying farewells to their these are like quite big children and they're just saying farewell to their pacifiers by just attaching them to the balloons and once and for all saying goodbye. And the other is like you're burying all the pacifiers in the ground, and the next day you might be finding some candies or a gift or something. Like you're just going to forget about them later. Next is speech and language development. Then there are developmental milestones that you can tell if the child has come to you and you know that there's something is different or out of normal. You can communicate it to the parents that these are some of the things that is not according to the age, like birth to 3 months, a child is not responsive or something, not babbling. I mean, something that you find it's out of the odd, you can always tell them, point them out, or maybe refer them that they might need to see a pediatrician or something. I mean, maybe the parents have not detected it as such, and you're the first one, so you can tell them. Next is childhood trauma or injuries. So the years of the life when the children are mostly affected by the trauma or they're prone to injuries is the toddler stage. Like when they start walking, they are not like pro in walking, so they're going to fall. They're going to be curious about different things. Maybe it's a hot water or anything. You have to just child-proof your house, or you should be always on a watch out that you should be avoiding it. If there are any traumas or injuries to the teeth or anything, you should immediately be seeking medical attention for that. And next is medications and antimicrobials. So presence of sucrose or any fermentable carbohydrates in the formulation of pediatric medicines and low pH contributes to caries. So you should be always on a watch out and telling the parents that either it's a multivitamin or that syrups or even the brufens and the painkillers and any kind of syrups, they are having sugar in them. So it should be used judiciously. And one of the most common practices is you get to the syrups that are not that much sugary, they tend to add more. So it's going to increase the cariogenic potential instead of giving you benefit, giving your child benefit. In children using medications like chronic conditions like asthma, epilepsy, upper respiratory tract infections, they're also associated with caries. So this is like a good oral health is important for you and your baby's overall health. It's overall health. It's like it starts prenatally and it ends. It never ends actually, but it goes on with from the newborn stage to the babies and the toddler stage and till adolescence and adulthood. So what happens is the takeaway message is like there have been many advancements in pediatric dentistry, making it exciting to practice. Like this current time is like an exciting time that you have like got a lot of things available. There are like more prevention, ways of prevention, tools of prevention, early intervention things. You can just do reparative care. You can do the interim therapeutic procedures, and you can go for like all you have all the new advancement like the lasers and which are giving more ensuring the patient satisfaction and as well as long-term effectiveness of the treatment. You're just ensuring both and applying anticipatory guidance to pediatric dentistry. It's an organized way for all dental practitioners to gain parents. This is like I think the best time where you can practice pediatric dentistry. Like we have many advancements, and for either we say prevention, for intervention, for reparative care, and I mean it's giving you the patients are satisfied and they can be satisfied with the treatments you are going to provide, and long term effectiveness of the treatment is always given is also given. And applying anticipatory guidance, it has helped us in gaining parents' trust and by increasing their knowledge and their awareness, and they're more ready to deal with their child's oral health. And with them, it works as a team. And when you work as a team, you're going to be able to achieve something which is like near optimal or optimal oral health of the children. And early dental interventions using prevention and anticipatory guidance is the next frontier in dental caries reduction. So this is so it's always about prevention and anticipatory guidance that it can just help us promote the child development and prevention of the child from going into or more of the harmful effects of the dental caries, etc. So thank you for listening.
Thank you so much, Dr. Maleeha Ijaz, for that insightful presentation. Your expertise in pediatric dentistry and the modern approaches you have shared today have truly been valuable. Now we'd like to move and hear from our audience. We will be moving to the Q&A session where Dr. Maleeha will answer your questions. So for the first question, we have Dr. Adila who is asking that for the teething, what do you do if at home remedies such as cold cloth is not working? Can you prescribe any kind of gel in those cases?
No, this is the thing that I was telling you that even most of the parents and practitioners they're like, can there be that numbing gel, that lidocaine gel that can apply? No, no, no. Even we don't apply it when the child is there in the dental department because if we do that, we don't know how much the child is going to ingest. It's the same as if a child has ingested a tube of toothpaste and you don't know how much fluoride has the child ingested, so you never know systemically. So you never do that. You are going to rely on the local or at home remedies like massaging and cold foods and cold teething drinks, etc. And then later maybe paracetamol or brufen syrups can be used. So that's it. That's it.
Mm-hmm. All right. Okay. I hope that answers your question, Dr. Adila. The next question we have is by Dr. Abdul Salam, and
Mm-hmm.
he is asking, can you tell how to differentiate between rampant caries
Mm-hmm.
and ECC, the early childhood
Early
caries?
childhood caries. So
Yeah.
rampant
Yep.
caries is basically
Mm-hmm.
the aggressive form where you find the incipient lesions on the interior teeth. This is usually the rampant caries is with the bottle feeding. It's a typical presentation where you will find the teeth, mostly affected teeth would be the upper interiors, the maxillary interiors, and the upper upper molars. So these are some of the classical presentations that you're going to differentiate. That is how you're going to differentiate. Because ECC could be anywhere in the mouth, but for rampant caries, it's always in that region.
All right, perfect. I hope that answers your question, Dr. Islam. The next question we have
Okay.
is
Scope of
that
feed.
could you please mention the scope for PEDS?
Okay, it
Yeah.
the thing is that if you are if you know, I would say if you know about like in the latest is like the PMDC is just trying to have pediatric dentistry as a separate subject for final year professional education. So if that happens sooner, yes, in KPK, yes, we do have degrees in KPK. These are like DCD that is happening in Faber College of Dentistry. There are many colleagues and seniors from there who have done like a 2 years. I think it's a 2 year diploma. Yes, the DCD is a 2 year diploma. It's not a master's degree like 4 years, but it's more like a diploma thing, which is recognized by HEC. So you can go for that. And for scope, I would say it is good if you have that compassion and what you call the tolerance. If you're good with the kids, then only you should be proceeding with this degree. That's what I think it should be.
Okay, so it has a great potential in
It
future,
has, it
inshallah.
has,
Yeah.
it has. But you should be dedicated enough to continue because it's tiring because you have to talk a lot with the kids while dealing with them. So yeah, you should be buckled up for that.
Definitely, dedication is the key. So our next question is by Dr. Bharat Kumar, and he is asking that how do you handle mentally challenged children
Yes,
in the private
mentally
clinic?
for we would use for this mentally retarded, we usually call them special healthcare need children, and you should always be referring them like that. And like for the differently able children, what happens is since the cerebral palsy is the main thing where the child doesn't know about the surroundings, the autistic patients and all. So we generally, apart from doing any preventive like toothbrushing or generally examination, apart from examination, you cannot perform treatments because they cannot stabilize themselves while they're under pure treatment or on the dental chair. So what you do is we prefer if they have if they need extensive treatments, like most of the times they need extensive treatment. So we take them to general anesthesia because even in conscious sedation, they're not going to cooperate with you. They're going to be more movement of their extremities. So you're going to have them stabilized, so which is possible only under GA.
Okay, got it. Amazing. So the next question I would like to ask is about lasers. So you know how people come in with the complaints of ulcers, like for example the aphthous ulcers? How effective and significant is the lasers in treatment of the lasers?
If you say like laser dentistry, first is do you have laser in your setup? Second is are you acquainted with it? I mean, how to use it? And is your laser suitable for soft tissues or hard tissues? Then, if these all of this criteria is being met, then the next thing would be you can use it for Estes ulcers because latest in according to the American Academy manual, if you get to read that, if you want to, you can always consult it while doing different procedures because there are recommendations and policies. So it is written that it can be used. If it's a soft tissue laser, you want to use it, you can just because what laser does is the light is going to hit that soft tissue, the crater, the ulcer, and it's going to actually what you call it coagulate it sometimes. So when it evaporates it or coagulates it, what is it? It's going to decrease the span of that lesion. So there would be less pain and there would be less symptoms of like burning or irritation with the cold or hot food the child is taking. So yeah, yeah, that can be used.
Okay, perfect. Right. So we have discussed pacifiers, right? And what do you think is the significance of ortho pacifiers when compared with the conventional pacifiers?
Actually, pacifiers isn't entirely different presentation. If you want to know more about pacifiers, we can always discuss about the designs and the types of pacifiers and what type of pacifiers are to be given at what age. I mean, there are pacifiers that have like different nipples, they have different designs, they are different dimensions. So you're going to use them accordingly. I mean, it's not like one straight answer to this, like this is the one thing that is going to be used. So it's always going to take maybe another presentation or something or a discussion.
Right. So the
Yes,
pacifier, as such,
yes.
is a big topic to be discussed. But in bird's eye view, the ortho pacifiers are comparatively way better than the conventional pacifiers that are used
Yeah,
by
yeah.
the
I mean,
parents.
every new thing is like it reaches the common people like a little later, and in our countries, I mean, even a bit more later than, and it's difficult to even what you call as adapt to the newer things. So when they do, they do, but most of the times it's the old conventional ones that are being used till now. So yeah,
Right, definitely. And as dental practitioners, it is our responsibility to
yes.
provide the education to the parents and as well as the patients. Before I let you go, Dr. Maleeha, just one last question. And it is that Dr. Maham is asking, can you compare the procedures done under the GA and the procedures compared with the
Mm-hmm.
inhalation sedation? Like we discussed before, the special healthcare patients that are coming to the clinic, what if we provide inhalation instead of GA?
Actually, it's about the level of cooperation because there's a criteria that has to be met for inhalation sedation. Because if your patient falls under ASA classification and the patient is ASA 1, 2, and the child is like mildly cooperative and the child does not have like any breathing issues, like he is not a oral or mouth breather, so doesn't have asthma. I mean, he can just take that hood off that nitrous oxide sedation comfortably. And you know that and with this nitrous oxide sedation, you cannot just do procedures for like 2 or 3 hours at the end. Like in single visit, you're going to do quadrant dentistry. You're going to split your treatment under like at one quadrant, if like 2 teeth or 3 teeth, and you know like this much work has to be done, then you can do it. But GA is like quicker. GA is for like patients who we cannot control their movements and who cannot understand our commands. And you never know because with what happens with endolysis or this nitrous oxide sedation is like the child can actually quickly slip into this paradigm of like the child can lose consciousness. And if the child is not able to tell you or verbally respond to your commands, then what happens is um, you're going to lose the child and he's going to be unconscious and you would never know that what is happening. So it's better that you, before proceeding with, you have to have a proper criteria be met, be it general anesthesia or be it chairside inhalation sedation, etc.
Right, perfect. So basically, you've brilliantly answered that. What we have is that we have better command when it
Yeah.
comes to general anesthesia and challenged patients when compared with the inhalation sedation. Right. Lastly, that was a fantastic discussion. Big thank you to everyone who participated in the Q&A session. Your questions made this event even more insightful. And of course, another heartfelt thank you to Dr. Maleeha Ijaz for her time and expertise today. We truly appreciate your valuable insights and guidance. Your knowledge and dedication to children's oral health are truly inspiring. I also want to extend my gratitude to all the attendees for being an active part of this webinar. Your engagement and enthusiasm contribute to the success of sessions like these. Before we conclude, a quick reminder, please fill out the feedback form. It helps us improve for the future webinars. Certificates will be issued to those who complete the form, so don't forget to submit yours. If you have any further questions or would you like to connect with us, feel free to reach out to us on our social media platforms such as Instagram, Facebook, YouTube, LinkedIn. Dr. Maleeha, if you'd like to say something.
Thank you so much for having me. It was really nice talking, although the presentation glitches were there. But even after that, I really enjoyed answering the questions. And even learning more while I was preparing the presentation. So thank you so much. It's
Amazing.
a
That's
pleasure.
amazing. So once again, thank you all for joining. We look forward to seeing you at our future events. Have a wonderful day ahead.